good afternoon, and thank you to the organizers for this very nice initiative. So the title of my talk today is Evaluation of the Prognostic Role of Circulating Tumor DNA and Circulating Tumor Cells in non-small cell lung cancer patients treated with pembrolizumab. Non-small cell lung cancer describes any type of epithelial lung cancer, such as squamous cell carcinoma, large cell carcinoma, and adenocarcinoma. For advanced metastatic patients, most treatments, including chemotherapy, surgery, radiotherapy, and inhibition of specific pathways, are in general not curative. So in recent years, immunotherapy approaches have been developed that target the program death ligand 1, also known as PD-L1, and its receptor PD-1. An example is pembrolizumab, which is an anti-PD-1 antibody. So although pembrolizumab seems to benefit a proportion of patients, the majority are non-responsive, suggesting that intrinsic or acquired resistance to treatment may be involved. Therefore, the success of pembrolizumab and other immunotherapy approaches depends on choosing patient populations who are most likely to benefit. Although PD-L1 expression on tumor cells has emerged as a biomarker to predict patient response to immunotherapy, it shows limited predictive value, and this is because patients with tumors that were negative to PD-L1 were still responsive to pembrolizumab. Therefore, we need to identify alternative and more accurate predictive biomarkers. So liquid biopsy in terms of cell-free DNA, circulating tumor DNA, and circulating tumor cells has become very popular because it can provide clinically valuable information in lung cancer, and to be more specific, changes in the numbers of CTCs or in the levels of ctDNA could be used to characterize alterations in tumor burden and therefore to monitor patient response to treatment. Also, the advantages of liquid biopsy are that it is less invasive, it has a lower cost compared to traditional tissue samples, it helps to capture more of the heterogeneity of the tumor, and it can be taken even after surgery and during treatment. However, cell-free DNA is easily degraded, and also there is a low content of tumor cells in the sample, making their isolation very challenging. In this study, we aim to investigate the predictive and prognostic value of cell-free DNA, ctDNA, and CTCs at an early phase of treatment in advanced non-small cell lung cancer patients treated with pembrolizumab after first-line platinum doublet chemotherapy, and also to identify somatic mutations in ctDNA that can be used as molecular biomarkers to monitor treatment efficacy or resistance. So we isolated cell-free DNA from plasma samples of 32 individuals before and after treatment with pembrolizumab, and we used cell-free DNA in next-generation sequencing for the discovery and quantification of somatic mutations. In addition, CTCs were identified in cytospins of peripheral blood mononuclear cells and were further characterized according to PD-L1 and Ki-67 markers. Patients were evaluated based on their progression-free survival, PFS, and were classified into either durable or non-durable clinical benefit based on a cutoff value at 6 months. Our results demonstrate that CTCs were detected in 94% of patients before treatment and 63% of patients after the second cycle of pembrolizumab. PD-L1 positive CTCs were also identified in both patient groups, durable and non-durable clinical benefit, and at similar percentages. And regarding the Ki-67 marker, we saw that a higher percentage of non-durable clinical benefit patients were positive for this marker compared to durable clinical benefit patients. Comparative analysis also indicated that the percentage of Ki67 positive CTCs was significantly higher in non-durable clinical benefit patients compared to durable, and survival analysis also showed that those patients who had more than 30% of Ki67 positive CTCs had significantly shorter PFS and OS overall survival compared to patients with a lower Ki67 index. Changes in cell-free DNA levels from baseline to post-second cycle were also evaluated as percentage changes for each patient. And in order to evaluate whether cell-free DNA kinetics could be used as a predictive or prognostic marker in this patient cohort, we performed ROC curve analysis, which set a cutoff at 12.8% increase in cell-free DNA levels. Interestingly, we saw that for those patients with a high percentage increase in cell-free DNA, 80% had non-durable clinical benefit, so a PFS lower than 6 months, compared to only 20% who had a durable clinical benefit. For those patients with a lower increase or a decrease in cell-free DNA levels, 53% had a durable clinical benefit and 47% non-durable clinical benefit. So using the same cutoff value, we performed a survival analysis, and we saw that patients with a high increase in cell-free DNA had a higher risk of progression and also significantly shorter PFS and OS compared to the rest of the patients. For next-generation sequencing, we use the Oncomine lung cell-free DNA assay, which covers more than 150 hotspots in 11 genes, including ALK, NGFR, KRAS, NRAS, TP53, and others. So this assay allows the detection of both single nucleotide variants and short indels with a limit of detection down to 0.1%. And this is what makes this assay much more sensitive compared to other more conventional assays like AmpliSec, where the limit of detection is around 5%. NGS was performed in 21 of the 32 patients, and somatic mutations were identified in 48% of the patients in TP53, NGFR, KRAS, and ALK genes. So we initially evaluated the somatic mutations in terms of their molecular frequencies, and we identified 2 patterns of molecular response in durable clinical benefit patients. So the first one was a patient who showed a dramatic decrease in ctDNA over time. And the second pattern were patients who showed clearance of ctDNA eventually during treatment, even at the presence of high mutational frequencies at previous time points. Regarding the non-durable clinical benefit group, the mutational frequencies varied, so there were no clear patterns. So then we moved on, and we wanted to further evaluate our somatic mutations, and we classified them basically according to previous bibliography. We had 2 groups. The one group were mutations that were associated with a good response to pembrolizumab or other immune checkpoint inhibitors, and the second group were mutations that were associated with poor response to pembrolizumab or other ICIs. And we saw that actually our patients who were carriers of poor response mutations had a significantly shorter PFS and OS compared to patients who did not carry such mutations. In addition, the presence of KRAS mutations either before or after the second cycle of treatment was significantly, had a negative effect basically on overall survival, with a 6.45 higher mortality risk, and also a significantly shorter overall survival for carriers of KRAS mutations compared to non-carriers. You can see that the median overall survival was 9.65 months for carriers and 36.3 months for non-carriers. The number of KRAS mutations also negatively affected the overall survival of patients, with a 10 and 5 times higher mortality risk for each KRAS mutation that was identified before treatment or after the second cycle, respectively. So we saw earlier that a high cell-free DNA increase greater than 12.8%, and also a high Ki-67 index greater than 30% were negative indicators of patient response to pembrolizumab. So we then examined whether the combination of these two markers could provide more information, and we actually saw that patients who presented both of these markers had a significantly shorter PFS and OS compared to patients who did not present these markers. So our question was whether this combination of cell-free DNA dynamics and Ki-67 index could result in improved sensitivity in the detection of patients with poor outcomes. So patients that had a non-durable clinical benefit and a PFS lower than 6 months. We saw that for our non-durable clinical benefit patient group, 73% and 36% had a high Ki-67 index before treatment or after the second cycle, respectively, whereas for our durable clinical benefit patient group, none of the individuals presented a high Ki-67 index, and this actually confirmed the specificity of this marker. So when we counted the number of individuals that presented either a high cell-free DNA increase or a high Ki-67 index or both of these markers, the sensitivity was calculated to 71 and 67% for each time point, respectively, which was similar or even higher than the sensitivity of either of the biomarkers alone. To conclude, in this work, we showed that evaluation of CTCs and Ki-67 index, and also of the mutational status before or at an early phase of treatment with pembrolizumab, could be used as indicators of resistance or response, that the monitoring of KRAS mutations seems to be prognostic of patients' outcome, and also that the combined evaluation of cell-free DNA and Ki-67 index could provide increased sensitivity in the detection of patients who are most likely to progress. So all these results aim to facilitate the diagnosis and selection of patients that would benefit from pembrolizumab, and subsequently to give the chance to patients with poor response to alternative treatment options that could potentially improve their outcome. So at this point, I would like to thank everyone who contributed in this study, our funding bodies, our patients who donated, and all of you who listened. Thank you.